We're obviously changing our program a little bit here, but I'm going to give 2 consecutive talks. The first one's on problem solving with CEUS, or what can we do elsewhere in the abdomen. And then we'll talk a little bit about hepatocellular carcinoma, which is really one of my favorite things. So let's start off, first of all, talking about problem solving. Is it even lighter than usual? Or just as light as before? Isn't
You're
it?
in the spotlight. It's very, the lights are very bright there.
Okay. Well, I know, but did we have 2 lights before? I thought there was only 1 anyways, regardless. So problem solving with CEUS. So ultrasound with contrast. We want to consider, first of all, that ultrasound gives us exceptionally good tissue information. And so as Richard alluded to previously, none of you would ever look at a CT or an MR scan for very many things without any contrast, whereas a grayscale ultrasound, particularly if it's performed with Doppler, it really gives us a tremendous amount of information. And when we add contrast enhancement, what do we get? Well, we get blood flow information at the perfusion level. And so actually this statement that I've just made really dictates things that I've done in my own career. And so when we're looking at any problem case that comes through our ultrasound department, I always say to myself, would contrast enhanced ultrasound give us information that might help us with this diagnosis? And so very often I think that it does. And so it's valuable whenever blood flow information might be contributory to the diagnosis. So in this presentation, we'll look at problem solving in the abdomen for organs other than the liver. And we'll emphasize the benefits, obviously, of no radiation, real-time dynamic scanning, which we've looked at already, the high sensitivity of ultrasound to its tracer, and the best sensitivity for arterial phase enhancement and improvement in patient care. So let's start off, first of all, looking at a few cases with a splenic mass. So the first patient is a 65-year-old male with hepatitis C virus. And this is an amazing patient who I knew quite well. He had a liver transplant in 2002, at which time he had cirrhosis and HCC. And then he had a tumor recurrence following his transplant, which was treated. And so we're way out in 2015, still doing surveillance scans on this very, very hardy patient. And so when he comes, I said to him, when I saw this mass in his spleen, I said, "How are you?" And he said, "I'm fine, Dr. Wilson." And I thought, really? And so I asked him more aggressive questioning, and he finally said, "Well, maybe I'm a little tired." But really, that's all it was. Maybe I'm a little tired. So what do we see? A hypoechoic mass in the spleen, and the spleen's not otherwise remarkable. And so, of course, my natural inclination is that we should do a contrast-enhanced ultrasound. And so when we do the contrast-enhanced ultrasound, this is the picture that we get. And so when I'm looking at this, I kind of rather thought that it filled a little bit from the periphery into the center of this mass. And of course, hemangiomas in the spleen aren't well described. And so I was thinking, gee, I wonder if this is a hemangioma. So we looked at these lovely pictures that we extracted from the clip. So we back up the clip and we get those lovely arterial phase images. But then at 56 seconds, the mass is black. So what are we going to think? Well, you don't know what to think because I haven't told you what to think, and there's hardly anything to read, so we don't know. But what I thought when I saw that going black was, I thought the same as we're so entrenched in our mind now that when things wash out, it's probably not a good thing. And so I'm looking at that washout and I'm thinking, this does not look good. So when I look at the later images, this is a big black hole in that spleen. And so I said, I think that this is concerning. And I think that this is showing washout, and that although we don't have good indication that washout always means something bad everywhere, I have a sense that it does. And at that point, I said, think malignant. And today, I would definitely think malignant when I see that washout like that. And so we would biopsy that, we recommended, and that's a B-cell lymphoma. And so they did only one confirmatory test, a PET scan, which confirms that solitary focus of abnormality. And so there's a lot of feeling out there in the clinical world that they would do that PET scan because probably an ultrasound scan might miss the other manifestations. And granted, I do agree that we might miss chest nodes, for example. If there are nodes in the chest, we can't look there. But where we can look, we do a really great job. And he said to me, is there going to be any other nodes in the abdomen or anything? And I said, not a thing. And I feel confident saying that. And that was what he had. So this was another patient who came almost on the heels of the one I've just shown you. So this patient also has no history of liver transplant or hepatocellular carcinoma, but this patient has PSC, surveillance ultrasound, with a hypoechoic mass, again in a fairly otherwise unremarkable spleen. So when we add color Doppler, we can see both perilesional and intralesional vascularity. And so when we do the contrast on this patient, I was really struck with the fact that I thought that this one looked very strikingly like the other one, seemingly filling maybe a little bit from the periphery into the center, homogeneous hyper-enhancing mass. So when we look at these arterial phase images, that's what we're looking at. So we can see that at 24 seconds it's hyper-enhanced, but here at 1 minute it's also hyper-enhanced. And so then when we look way out to 5 minutes, you can see that the mass is basically invisible. Once it enhanced, I never really saw it again. And so this mass is quite different than the other mass, and certainly this is not showing things that are making me concerned about this mass. And so we recommended that this would probably be showing sustained enhancement. So what am I thinking? I'm thinking again that this is probably benign. And so what can we assume from these different observations in the late phase? So washout, I'll show you quite a few cases as I'm going through this. In any organ, when I see something that enhances and then washes out quickly, I'm always going for the fact that we should be cautious that that's not something significant. Whereas when we see a mass that shows sustained enhancement to the point of being virtually invisible, even at 5 minutes, I don't think that's anything. So we've followed that last lady now for years, and that's never turned out to be anything, and it hasn't changed. So what about this patient? This is an elderly lady who's septic. And so the question is, could her source of sepsis be this mass that's in her spleen? So I didn't think this looked much like a splenic abscess, but in any case, you can see this mixed echogenic and hypoechoic mass in her spleen. And so again, we're going to give her a little contrast. So when we give her some contrast, again, she's breathing, which is not problematic. You can see that. And so you can see that this is actually just a complicated cyst in her spleen. It doesn't have anything about it that makes me think that it's a cystic neoplasm, and nothing about it that makes me think that it's a splenic abscess. So we thought that that was just a splenic cyst. Well-defined avascular mass suggests a complicated splenic cyst. So let's leave those cases of the spleen and look at a couple of really nice cases of the bowel. So this is a 59-year-old male who has crampy abdominal pain, and for 10 years they've been questioning whether he might have inflammatory bowel disease. And I will tell you that he had several CT scans in that interval. So when we look at this scan, you can see that there's something wrong with his bowel. So we're looking at his terminal ileum, but this doesn't look like bowel thickening. It looks like a mass, right? A well-defined black round mass related to the wall of the terminal ileum. So again, we do contrast on this, and we can see that this mass is hyper-enhancing, and then we can see that this mass is washing out very, very rapidly. And so the morphology suggests to me that that's most probably going to be a neuroendocrine tumor, and that is confirmed by biopsy, neuroendocrine tumor of the terminal ileum, and it's a really very classic appearance. And so since I've been in Calgary, actually the surgeons in Calgary have told me on more than one occasion that ultrasound is actually the largest source of small bowel mural tumors that we detect on imaging at the foothills. So more than CT and more than MR scan, we can really see these very beautifully, and many of them turn out to be neuroendocrine tumors, and of course some turn out to be metastases. Now this really sensational case was accredited to one of my very astute sonographers. So this was a young female who came again for a query irritable bowel syndrome. She had bowel symptoms. I don't think they had anything to do with what we found. So my sonographer brought this picture to me, and she showed me a lovely axial and long axis view, and she says to me, something's wrong with the appendix. The tip is bulbous. It doesn't have any wall layers. So you can see right at the point where she's put that arrow that the tip to the right of the appendix is a little bit bulbous looking, not particularly big, but bulbous looking, and that to the left there are wall layers, to the right there are none. So if we look at the bottom, you can see that we're looking at that appendix in the axial view, and when we do our contrast injection, you can see that as the contrast comes in, that in fact there's a little polypoid growth inside that appendix, and it's a hypervascular polypoid growth. So I watched that polypoid growth and I thought, I think they should take that out. So that was what I said, is I said we confirm a polypoid tumor with vascularity in the appendix. And so of course the issue is this a malignant or a benign tumor? And we don't know for certain. But so this patient, with that lovely ultrasound, they sent her for a CT. Now again, I don't have any problem that they send her for a CT, but I don't recommend it because I don't need to have a CT. But they did do the CT, and you can see by the little arrows I think I put on there. No, I didn't put them on. But you can see the appendix right on all the axial views, and on the sagittal view with a small arrow. And the appendix was shown in the CT interpretation. They knew what we thought. They just said we can't see or confirm any abnormality of the appendix. But nonetheless, my surgeons are very, very confident that when I tell them it's there, that it's going to be there. So they took it out, and that is a malignant polypoid tumor in that appendix. Now, what about the pancreas? So the pancreas is actually a really great area for ultrasound. But so this is a 60-year-old asymptomatic patient. And so she comes to us with an ultrasound history. So this is an ultrasound that was done in 2009. And you can see that we're basically looking at a pancreas that's made up of it's black, completely black. So we think that this is a great big dilated duct in her pancreas. And so when we look at MR, you can see on the T2 weighted imaging that this is her pancreas, and we don't see really too much more than that. And on T1, we can see that it's T1 dark, and again, not too much more than that. And so thought to have a main branch IPMN. Now, on a surveillance scan following, they operated on her and did a Whipple, which is unexplainable to me. But in 2012, she had a CT scan with rising C19-9. And so again, we can see this dilated duct in her pancreas, but not too much else was commented upon. So then she came for ultrasound with CEUS. And when we look at this, you can see that we're looking at the duct, but we can see polypoid growths inside the duct. So all along the duct, there's polypoid growths everywhere. So then I asked if I could have the 2009 ultrasound sent to me from the facility where she was at that time. And I feel in retrospect, there's no doubt she had those polypoid growths in her pancreas at that time as well. So when we do CEUS of this patient, you can see that she's got quite avidly enhancing polypoid tumors arising within that pancreatic duct. And so we said that this was a malignant IPMN, and this lady did have a total pancreatectomy with confirmation that she has malignant IPMN. So that's really probably about as nice a pancreas case as I'm going to show you. Now this is a young man with von Hippel-Lindau. And so his, when he came to see me, his MR interpretation was that of having a cystic pancreatic mass. So you can see that he's got a very T2 bright mass in his pancreas, quite small size. And when we look at it on T1, it's T1 dark and T2 bright. And with post-gadolinium, I think there is some enhancement. I'll let those lovely ladies over there from Northwestern tell me after if you think there's enhancement. I certainly thought there was, but they didn't call that. So when we looked at him, we're looking for a pancreatic mass. And when I look there, you can see that the pancreas is in fact abnormal and it's echogenic, but it's totally solid. There's no evidence of any cystic mass in the pancreas. So when we inject the contrast, you can see that there's uniform enhancement of that mass. It's in the pancreas, right in the pancreatic neck region, and just another view of it. So we confirm a solid and hyper-enhancing mass that's quite discordant with the MR scan. And so neuroendocrine tumors can certainly be discordant between CEUS and MR, usually showing more solid nature and hypervascularity on CEUS. Now, this is another patient, a 72-year-old female who comes with jaundice. And she has a CT scan that shows uniform dilatation of her biliary ducts without any evidence of a mass. On the MR scan, again, she's got uniform dilated intrahepatic and extrahepatic biliary ducts with no obvious mass. So finally, the patient comes for an ultrasound, and we confirm easily on the first moment that she does, in fact, have dilated biliary ducts. But when we look at her ducts, we can see on the transverse and the sagittal plane of the ducts that she's got intraductal mass lesions. And so are these stones or are these tumors? So what do? Of course, we do contrast, and we can see that these are, in fact, enhancing tumors in the biliary ducts. And so they're a big nodule right there with big enhancement on the CEUS. So we call this malignant papillary intraductal cholangiocarcinoma, and that was in fact confirmed, a mucinous cholangiocarcinoma within biliary papillomatosis. And so what does this show us? Well, there's one thing that I learned long before I started to do CEUS, and that is that if we're trying to characterize a cystic mass, any mass that's cystic, perhaps with septations or solid components within, ultrasound is the best. Is better than CT and MR. And Richard showed that in your kidney talk, of course. And so cystic renal cell carcinoma is the most familiar example. But all of the cases that we get related to the pancreas and the biliary ducts that have a cystic component with solid components within, ultrasound really resolves those solid components on grayscale and then allows us to evaluate them with CEUS. So what can we conclude? All of those cases show the extreme sensitivity of CEUS to arterial phase vascularity, and we'll see it regardless of its timing or duration. And it shows also the superior resolution of ultrasound for the internal contents of any cystic mass. Now, let me show you a few cases that relate to the peritoneum. So let's start off with a few cases of patients that have renal failure and the inability to have contrast-enhanced CT or contrast-enhanced MR scan. So this is a young female who had a recent renal transplant, and very soon after her surgical procedure, she presented with increased abdominal girth. So you can see her transplant kidney in her left flank, and then you can see this mass lesion, which looks like it's low attenuation with septations. So a big mass lesion, and this was thought to probably be a urinoma or a seroma related to her very recent surgical procedure with no discovery of any mass in her abdomen. However, after considerable imaging outside of ultrasound, she came to have an ultrasound with us. So when we look at this, just on grayscale again, we can see that this is a septated cystic mass. It's not a collection, it's a mass. And that those septations and that kind of low-level echogenicity, in my mind, down grayscale, that suggests to me that that's going to be a mucinous tumor. So we do contrast on this lady, and all those septations and all those solid parts are avidly enhancing. And so this is a confirmed mucinous cystadenoma removed surgically. Now, let me show you two similar cases. So these are both patients who have renal failure, compromised renal function. So the first is a 42-year-old male who was 6 weeks post-radical nephrectomy for a renal cell carcinoma. And he presented to the emergency department with acute right flank pain, and he had elevated creatinine. So the next test he had was an unenhanced CT scan. And so I'm sure that all of you who are in the radiology side of departments are aware that when patients present for a contrast-enhanced CT and the patient can't have contrast, they're converted virtually always to unenhanced CT scans. And then they have a report with a proviso that without contrast, the scan is compromised. So here we can see that the patient's got a big fluid collection in the right retroperitoneum, and we can see that there's some high signal material in the dependent portion of that mass, and there's kind of like a hematocrit with a fluid debris level in the lower quadrant. And so this was interpreted as a right retroperitoneal hematoma, which seems reasonable to me. The patient was admitted for pain control, and a couple of days later he was sent to my department for us to follow up this retroperitoneal hematoma. So one of my girls did these lovely pictures and brought them to me, and I said, "What is that?" And she said to me, "It's a retroperitoneal hematoma." And I said, "How do you know that?" And she said, "The CT scan said that." So I said to her, that we don't believe that in this department, so we have to prove it. So we do a contrast-enhanced ultrasound. So not so suggestive of hematoma in my mind. So when we do the contrast-enhanced ultrasound, you can see when we inject the contrast, there's beautiful enhancement of the liver, but then that retroperitoneal mass is showing very extensive enhancement as well. And then when we get to the portal phase and then sweep through this mass, you can see the extensive involvement with enhancing material in the retroperitoneum. So what is this? Of course, this is infiltrative carcinoma through the entire retroperitoneum in this very unfortunate and young patient who died obviously not very long after that scan. So here's a similar scan, a 79-year-old male with a history of transitional cell carcinoma of his left kidney, and he presents with right flank pain. So his creatinine is elevated, so he also has an unenhanced CT scan. So on the unenhanced CT scan, we can see his kidney, and we can see a very bulbous mass-like area behind his kidney with low signal attenuation. So is it intra or extra-renal, complex cystic, or solid mass? So those questions are hard to answer when you have an unenhanced CT scan. So when we come to ultrasound, we can see easily on the grayscale scan that this is not a renal mass, it's in the retroperitoneum, and it looks very black on this scan. And of course, when we go to doing the contrast scan on this patient, we can see the enhancement of his kidney, and we can see that this mass is in fact a completely black and avascular mass. And so here, the interpretation of a retroperitoneal hematoma is in fact correct. And so these two cases just really show the value of doing CEUS. So both of them show a retroperitoneal mass. And so in one case, the lack of vascularity supports that this is a hematoma, whereas in the other, that extensive vascularity really diagnoses that this is infiltrative carcinoma in the retroperitoneum. So CEUS in those with renal failure. So we have done a prospective study in our department. One of my wonderful students did this, and we looked at about 200 patients who came to our department for a CT scan who were converted to an unenhanced CT scan. And we recruited them, and we did an ultrasound on them, and then if we saw something, we would do a CEUS. And it's really astonishing the results we had in that study, how many tumors we found in the liver, in the kidneys, in all organs. And really, I think that consideration of contrast-enhanced ultrasound in the population with known or discovered renal failure is something that everybody should consider. And in addition to that, I feel if any of you are trying to show your administration people what benefits CEUS has, I think in that population, this is a unique and special benefit that CEUS affords. And so ultrasound definitely is superior to baseline CT. So what we'll see on an ultrasound will be far more than what they'll see on a baseline CT. And then CEUS is so far superior to an unenhanced CT that it's not really even worthy of description. Now, so the kidney, Richard is just waking up, so I'm going to show a couple of kidney cases. So after the liver, the kidney is really the most established organ for CEUS characterization. And so two pathologies in particular demonstrate the superior sensitivity of CEUS to its tracer. And Richard's shown you both of these. So this is cystic renal cell carcinoma and papillary carcinoma. And so this first patient is really quite a good scan. So this is a male who has Crohn's disease. He has a bowel resection and comes for evaluation of his Crohn's. And, oh, goodness, I don't know what's happening here. Something's wrong, but in any case, this case is out of order, but we'll show it anyways. This is a patient who has Crohn's disease who comes for evaluation of his Crohn's. And when we look at him, we see that he has a mass in the midline deep to a fistula. And we can see that inside the peritoneal cavity, he's got this black interdigitating mass that suggests a phlegmon. And so we do contrast enhanced ultrasound on that region to confirm that that's not in fact a pus-filled area, but is a phlegmon. And so differentiation of inflammatory masses is another exceptionally good indication for the use of CEUS. So we only see the phlegmonous mass there, and we don't see that there's any evidence of significant pus within. But so then we go to the fistulous tract, and so the fistulous tract, the patient has had sinograms, but the sinograms have not successfully shown connection to his organs. And so sinograms with radio-opaque contrast are often quite difficult, whereas when you take a very, very tiny cannula and put, let's say, 2 bubbles, just 2 drips of contrast into a 10 cc syringe of saline, you get this kind of in a picture. So you get incredible enhancement. So there you can see that we're injecting the contrast on the skin surface. And there you can see the fistula coming down. And there you can see on the right-hand image that the B marks the bladder. So the bubbles are going into the bladder. So there's a communication to the bladder. And then we can see, this is just the picture that's showing this. So this is the contrast coming down and going into the bladder. You can see the bladder on the left-hand side, and all those bubbles are into the lumen of the bladder. And then when we come to the bowel, that's deeper down into the abdomen, we can see that the lumen of the bowel is also filled with the microbubble contrast agents. And so we do this quite a lot now when patients are sent to our department for sinograms. Certainly any that are of any difficulty in terms of technical performance, they're easy to do with CEUS and very, very successful. So actually, Richard, I took the kidney cases out. That's where they are, in deference to your excellent presentation. So, so now we'll talk about the female pelvis. So female pelvic disease is very, very good. And there's many applications for CEUS. But first is in a young woman who has quite bad pelvic pain. And so when we look at this patient, we're looking at her sigmoid colon. And you can see on the mesenteric border of her sigmoid colon, she's got a plaque-like black mass which involves the wall of the bowel. So when we do contrast-enhanced ultrasound of this mass, so the morphology, as I'm sure all of you know, that's quite typical of the plaque-like deposits from endometriosis that we see related to the rectosigmoid colon. And so we get a very low level of enhancement. They're not hyper-enhancing, and they don't really show washout. So that's a very typical appearance. And this is a biopsy-confirmed endometrioma. So on that same patient, we're looking at her left ovary, and we can see that there's a cystic mass inside. And so when we do this mass with contrast enhancement, we see a little bit of enhancement around the rim of that solid component, but nothing that's untoward. It looks to me like ovarian tissue that's got just little bits of nothing in it. And so that's a very benign morphology. Now, this is another patient who has inflammatory bowel disease, ovarian mass found incidentally on ultrasound. So when we see this mass, what do we think that that is? Well, that looks like a retractile clot within the ovary. And so when we do CEUS on that mass, you can see that we don't see a single bubble anywhere in the mass. So how does this help us? Well, it helps us the same as the example that Richard gave earlier. We can say that this is a clot within the ovary that's accounting for its large size, and that we don't need to see that patient further in follow-up scan. So what about this patient, a 66-year-old female, pelvic pain and a right ovarian mass? So we can see that she's got a bulky ovary with a hypoechoic mass within. And when we do CEUS, we can confirm that that is in fact a hyper-enhancing mass. And so this is the most astonishing case really to me. So that turns out to be still a grade 1 carcinoma of her ovary. But I think that was found serendipitously really rather than as a result of pursuit. and that does show enhancement and then shows washout. Now, in terms of ablative therapy, when we're looking at the liver, this is different than what we're going to talk about elsewhere. So this is a patient who has two images on the left-hand side of the panels where we have a grayscale and then a contrast-enhanced image. So this is an HCC that's going to be ablated. So on the pre-ablation scan, we can see the tumor on the grayscale, and then we can see in image plate B that the mass is hyper-enhancing. So then the patient has the radiofrequency ablation, and then you can see that on the images that are taken immediately following the procedure, let's say about 20 minutes following, so that the gas cloud has gone away, we can see the tumor there, and then we can do the CEUS, and you can see that the tumor is completely avascular. So doing these immediate post-procedure scans, what does it do? It decreases the necessity for repeat ablation following for residual tumor. So how often do we see residual tumor? Quite often, not common, but quite often. So this is such an example. So panel A shows a patient who has an HCC that's marked with the arrow, and it shows hyperenhancement on the pre-ablation scan. So then the ablation is performed, and then the patient with microwave. And then the patient has a repeat scan post-ablation, so that's called post-ablation number 1, that's B. So you can see that the arrows pointing to the tumor at the very same depth and virtually identical to its appearance on the first scan, and superficial to it is the ablation zone. So what happens? Well, the microwave ablation technique does not involve the same it doesn't secure the device in the tumor, and it can withdraw much more easily. And so that's what we believe happens here, is that the device has withdrawn a little bit, and that instead of ablating the tumor, they've ablated the tissue in front of the tumor. So this is, again, very easy to see. So you can see that post-ablation scan number 2, or panel C, shows the ablation site, the original one, and then a new ablation site that ablates the tumor. And so the physician who did this, he said to me, "Stephanie, I realize that this has a tremendous impact for this patient." He said, otherwise he'd have been out there for at least a month with that fully untreated tumor waiting for all kinds of things to happen. So this is another example of the benefit for ablation. So this is a patient who's had previous ablation procedures. And if you look at panel A, I realize how small it is, but you can see that there's 3 arrows pointing to 3 achogenic components of a mass. We know from MR scan that there's some enhancement within that mass. So when we look with contrast, I would have probably picked the biggest one as likely to be the one with the tumor, but to my surprise, it wasn't. So you can see that the 2 superficial components are black, completely avascular, and that it's that deep met portion that's hyper-enhancing. And then C is just with time, where it's hyper-enhancing and then shows washout, confirming that it still has LR5 characteristics. So we ablate that, and then following the procedure, the whole mass is completely avascular. Now, contrast-enhanced ultrasound of the bowel. I apologize for my spelling of. But so this is one of my really favorite areas. So the liver and the bowel I'm crazy about. And so for my whole career, I've been trying to convince everybody in the world that they should use ultrasound for surveillance of IBD. And so everybody in my environments everywhere uses CEUS and ultrasound, but it's a very, very hard sell in North America to get anybody else to. But so what we're evaluating now in our department is the use of both CEUS and elastography in the bowel. And we evaluate those two as non-invasive biomarkers that we believe help us, first of all, to determine if patients are likely to be receptive to medical therapy, and also to determine if patients have chronic or inflammatory strictures to help with selection of patients that should go to surgery. And so when we do a bowel assessment in my department, we're not going to go over this, but we have parameters that we look at: wall thickening, color Doppler signal, and inflammatory fat. And we have a grading scale for all of them to grade them as inactive, mild, moderate, or severely abnormal. So we've been doing that for years and years and years and years. And so here's just examples where we're looking with normal in the top left corner and most abnormal in the bottom right corner. So wall thickness from abnormal to very thick, inflammatory fat from no fat in the upper left corner to big perienteric inflammatory fat on the bottom right corner. And then when we come to color Doppler, again, no signal on the normal bowel, and then you can see progressive amounts of signal in both the bowel wall and in these perienteric fat. And so we feel that this has worked really well for us. And then increasing severity also shows loss of bowel wall layers and spiculation of the border of the bowel. And so, of course, when we're looking for disease extent and activity, we look at bowel that's thickened, such as here, where it has a thick wall and lots of inflammatory fat. And then when we try to determine disease activity, historically we've used color Doppler in that we interpret blood flow as reflective of inflammation in the bowel wall. And this is assessed with color Doppler and today better assessed with CEUS. So when we're looking at our picture again, if we add color Doppler, what do we see? We show very profuse vascularity in the wall of the bowel and in the mesenteric fat. So the weakness of color Doppler, of course, is that it's not so good in obese patients. It's not so good when it's deep. And of course, the biggest problem it has is that it doesn't tell you anything about perfusion about blood flow at the perfusion level. So contrast-enhanced ultrasound provides subjective and objective evaluation of the blood flow. So the subjective is a qualitative assessment of how the enhancement looks. And we can see transmural enhancement and a comb sign with vessels in the mesentery. And then objectively, we look at a time intensity curve and we measure the blood flow parameters. So I'll just show you in terms of subjective evaluation. Here's a schematic of the bowel and then a picture of the bowel showing the transmural enhancement and the supporting vessels in the mesentery. Just another comb sign with more vessels in the mesentery. Now, when we're looking at the TIC curve, we can see here that this is quantitative. So here we can see, when I click this button, there's two regions of interest within that bowel wall. And when we inject the contrast comes to a peak of enhancement, and then gradually declines towards the baseline. So this is a 2.5-minute clip that I've shortened down to about 20 seconds. And so from those nice clips that we can get, we can measure various parameters of blood flow, which are listed here, but they reflect the fractional blood volume, the blood flow, and the transit time. And so then when we have a nice time intensity curve, such as we see right here, we can see all those parameters. So how do these look when we're actually doing them? So we put 4 regions of interest just for quality control. And you can see we're looking at a linear representation in the middle. This is all based on raw linearized data, but a linear evaluation and a logarithmic display on the bottom. And so we do all of this on all of our patients. And we've now integrated these values in with our other evaluations of the bowel wall. Now, when we're looking at strictures, the question that the clinicians ask us is the stricture inflammatory or is the stricture chronic? So what we found is that there's an inverse relationship between CEUS and elastography. So the stiffer the bowel wall gets, the less blood flow it seems to have, whereas acutely inflamed bowel is soft. So when the CEUS is very high, the elastography values seem to be very low. So let me just show you an example. This is a 49-year-old male who's had Crohn's disease since 1982, and he has obstructive symptoms, and he's been on no meds for many years. So there is his terminal ileum. Does that look like a terminal ileum? Hardly. It looks kind of like a torpedo. So a big black loop of bowel, no bowel wall layers, fixed luminal apposition, and inflammatory fat. So this looks like a very bad loop of bowel. So the bowel proximal to it shows evidence of increased caliber and increased peristalsis. So you can see that we have dysfunctional to and fro peristalsis. So not only does the patient have evidence of stricture, but he's got evidence of pre-stenotic dilatation with dysfunctional peristalsis. Now, when we put color Doppler on there, we can't get any signal really at all, virtually nothing from the bowel or the inflammatory fat. When we do our CEUS, you don't know the values for these parameters, but these are about as low as it gets, so very little inflammatory activity. But when we measure the elastography of that loop of bowel, this is using point shear wave elastography, these values are very high. It's like a pipe. And so we say this is a chronically stiff loop of bowel, little blood flow, and this bowel should be removed. And so this patient goes to the OR, has a resection, and has a chronic stricture. Now, what have we looked at? We've looked at multiple different organs with different problems, and I hope I've shown you that CEUS may provide benefit in any situation where blood flow information may be contributory. Thank you. Any questions? No. So we could obviously do many other things, but those were just some examples. I thought I would show you.